Okay, wonderful. Thank you everyone for joining us this afternoon, if you're on the East Coast at least. My name is Nora Crossno here. I am one of the organizers for our short course Methods for Measuring Patient Preference Information. I'll be speaking to you today along with three wonderful colleagues, Drs. Brett Hauber from TI Health Solutions, John Bridges from the State University, and Ellen Jansen from Janssen Pharmaceutical. And we'll be providing an overview of some of the methods that you can use in measuring patient preference information, some practical applications of these methods, as well as some case studies to help explore the contexts in which they are most useful. We don't have anything to disclose today. We'll start by giving you kind of some practical understanding of this variety of methods for measuring patient preference information with a specific focus on discrete choice experiments, best worst scaling, threshold techniques, and direct elicitation. A few logistics. Today we'll start with an overview of preference methods. That'll be Brett who leads us through that. John will talk about some good research practices for designing our preference surveys. We'll have a little bit of a comfort break at around 2:30 and then come back to do a walkthrough and analysis of a preference survey and some final case studies. Logistically, I believe John wrote this in his introductory email. We're going to ask everyone to put questions in the chat box, and then I'm going to be moderating the chat box, and I'll flag those questions and sort of the appropriate part of the agenda as they arise. And you are, of course, welcome to stick around during the break and after the session, and we can have a little chit chat further, or always contact us by email or other means as we go through the seminar. And hopefully after all of these things are done, we'll leave you with a knowledge of a variety of different types of research questions and objectives that can be answered using patient preference information, and this general understanding of how to design preference studies and how to analyze and apply preference information to help us improve our research practices and better understand what matters most to patients and their loved ones. So with that, I will hand it over to you, Brett.
Hi, Nora. Thank you, everyone. Nora, if you can stop sharing, and then I'll pull up mine, please. There we go. All right, I believe we can see that. So hello, good afternoon, everyone. My name is Brett Hauber. I am a senior economist and senior fellow at RTI Health Solutions. And I am also an affiliate associate professor at the University of Washington in the Choice Institute at the School of Pharmacy. So my job today is to provide a very high-level overview of patient preference methods in general. And I'll give some specific examples, but really even those are pretty high level. And maybe as we go through a little bit further through the day, some of the examples that you will see will provide some more detail, and certainly we can answer any questions or provide references as we go along. But when we talk about patient preference information, which is the topic we're here for today, there is actually a definition in FDA guidance, which tends to be the prevailing definition currently. And it reads as such: qualitative or quantitative assessments of the relative desirability or acceptability of specific alternatives or choices among outcomes or other attributes that differ among alternative health interventions. So that's a mouthful. But what is included in there really captures, I think, the essence of what we're talking about when we're talking about preferences. So there are a couple of items I just want to bring to everyone's attention. First, the idea of preferences when we talk about measuring preferences is that preferences are relative, meaning that I can only say how good one thing is or how much I prefer one thing if I'm comparing it to something else. So even in cardinal measures like health state utilities, where I have a number that has a meaning, that number really is a comparison between two other a health state and two other states of the world. Likewise, when I'm looking at preferences in a discrete choice experiment, I'm looking at a relative utility gain from one change compared to a relative utility gain from another change. So we always need to keep in mind that we're not talking in absolute numbers here necessarily when we're talking about preferences. The next thing that I want to point out in this definition is the use of the words desirability and acceptability. I'm an economist by training, so when I use the word preferences, I tend to be agnostic as to whether they represent good things or bad things. But when we would talk to some people and we would say having preferences for risk, or risk preferences, people would be a little bit confused because they would assume that the word preferences had a positive connotation. So how could you have preferences for a negative thing or a bad thing? So in this definition, the word desirability captures the positive preference for good outcomes, and the acceptability represents the desire to avoid the bad outcomes, or how much you are willing to accept of a bad outcome in order to get something good. And then finally, in this definition, it talks about attributes that differ between options. And this is critical because if everything is the same between two options, then preference information really doesn't matter. There is no choice to be made. It could be a coin toss if there are two things that look identical and you just have to pick one. Preferences really matter when there are differences, and that those differences influence what people will choose. So we focus on the attributes that differ. Often when we're talking about medicine, we'll talk about certain treatments that have a common set of side effects. Frankly, if the side effects are common to all interventions, they're not necessarily relevant to the decision that I'm talking about. I want to really zero in on what are the differences among those options, and then based on those differences, what would I choose? So to put patient preferences into perspective, there's a really nice outline in the guidance from the Center for Devices and Radiological Health at FDA that starts with this broad concept of patient input, which really, I'll show that definition in a minute, but it really is broad. It would be any type of information that you could possibly get from a patient regarding a medical technology. Then there is this issue of patient perspectives, which is still a pretty broad concept, but a little more narrow. I want to point out here, when we're talking about patient perspectives, the patient perspectives in the guidance from CDRH, which is the devices group, is very similar to the definition of patient experience data that you will see in the guidance that was put out by the drugs group in response to the 21st Century Cures Act. Among patient perspectives then, or patient experience data, there are two types of data. One is patient preference information, and the other is patient reported outcomes. We're going to focus on patient preference information today, and I will take a moment to look at the distinction between patient preferences and patient reported outcomes in the next couple of slides. Actually, this slide. So often when we talk about patient perspective, people will say, well, we'll get a patient reported outcome. We'll get the patient's impression of what is happening as a result of this intervention. And that is different than patient preference information. Remember, patient preference information really is a statement of a judgment from a person about the desirability or acceptability of certain outcomes or certain products, where a patient-reported outcome, in contrast, is actually a realized outcome. It is a statement of what is, or what it is like, that is taken from the patient because there is no other source for that information. You need to ask the patient directly, but it's not a judgment as much as it is reporting about an outcome. So that is the primary difference between patient preference information and a PRO. Another term that often comes up is that as synonymous with patient preference information is multi-criteria decision analysis, or MCDA. And they are related, but they're not the same thing. Remember, patient preference information, the way that we're going to use it today, is really quantifying measures of desirability or acceptability. And MCDA is really a process for decision making. It's a methodology. And what it does is it takes the attributes or criteria of a treatment. It looks at the performance of all the options on those criteria, and then puts weights on those criteria in order to come to a decision. In our case, the weights are preferences. The weights, if they come from patients, are patient preferences. But the overall process itself of a multi-criteria decision analysis incorporates preferences, but is much broader than preferences. So when we're talking about patient preference information and we're talking about MCDA, we are talking about two different but related things. Likewise, when we talk about patient preference information and quality adjusted life years, again, we're talking about two different things. They are related in that a quality adjusted life year is a weighted measure of time in different health states. And it is those weights that can come from patient preferences or from preferences of the general public or others. I mentioned earlier, health state utilities derived from patients using TTO or standard gamble are patient preference measures. They can be used to weight those health states to generate estimates of QALYs. So again, as similar to what we have with MCDA, patient preferences are a component part of, or can be a component part of, quality adjusted life year calculations, but they are not in and of themselves quality adjusted life years. And often quality adjusted life years don't even use patient preferences. They'll use preferences from the general public or from other stakeholders. So I've mentioned a couple methods already about that we might be able to use to elicit patient preferences. And there are two sources that cover sort of the range of methods that could be available. The first is a catalog of methods put out by the Medical Device Innovation Consortium back in 2015 that groups methods based on essentially how they're used. So the structured weighting methods are typically used in multi-criteria decision analysis. Health state utilities are typically used in cost utility analysis. And stated preference methods are typically used often as standalone methods, but are sometimes then combined with clinical data to provide context on different programs. And then revealed preference data, as they're defined here, were kind of obscure and rare, at least among preference researchers, until there was a study using direct question in a clinical trial that was actually wound up in a label, and I'll describe that one in a little bit. The second source for looking at different types of methods is a compendium of methods that was put together by the IMI Prefer Consortium. IMI is a public-private partnership in Europe, the public part being funded by the European Union under the Horizon 2020 program. And Prefer is one of the projects there. So it involves academics and industry from both the US and Europe, also includes some regulators and HTA members as well. And one of their work products was to review available preference methods and to organize them, then to evaluate them and do case studies, and eventually to provide recommendations for good use. But part of that project, the Compendium of Methods, was published just last year in Drug Discovery Today. There's significant overlap between these two compendia. The IMI Prefer compendium tends to have a few more items in it. But fundamentally, it's very similar to the MDIC catalog of methods. So taken together, I think these provide a very good source for different methods. So let's look at a couple different methods here, starting with the discrete choice experiment. So in a discrete choice experiment, patients are asked to make choices between different hypothetical profiles. So in this case, each column represents a profile of some sort. Each profile is defined as by a set of attributes. And in this case, they are outcomes of the intervention. And those attributes can vary and take on different levels. And then each profile is determined by an experimental design and is a combination of attributes and levels. That experimental design also sets up our profile pairs. And then over a series of questions, individuals are asked to tell us which they would choose if they were the only options available. And then when we look at the pattern of choices, we are able to get preference weights or utility weights on each of the attribute levels. And differences between those attribute levels, in the preference weights between those attribute levels, reveal the relative utility of, or the change in utility from that change from one to another. And again, they are relative in that this 0.9 that you see here that you get by reducing or this 0.9 decrease in utility that you get by increasing this risk of heart attack from 0.5% to 1.5% in and of itself has no meaning until you compare it to an improvement in ambulatory pain from what is very severe to mild, or sorry, from severe to mild, which is approximately equal change in utility, so that what we can say is that one of these changes offsets the other. So even though the 0.9 in and of itself doesn't have a direct interpretation, when we look at one relative to the other, we can begin to see the pattern of trade-offs that patients are willing to make. And then by doing so, we can look at the relative importance of the different attributes in the study. So in this case, avoiding a heart attack is the most important attribute, whereas improving ambulatory pain or reducing ambulatory pain and reducing the impact on daily activities are second to the cardiovascular events in this study. And then we can use that to estimate things like maximum acceptable risk. What is the maximum level of risk that I would be willing to accept in order to get some improvement, in this case, reductions in the level of pain? So an alternative to this, if you think about the DCE, we're looking at changes in all attributes simultaneously. So we're estimating this joint model of multiple changes. When we could narrow that down and look at specific pairwise changes. So in this case, we would call this a threshold technique, where we look at the trade-offs between two attributes, and at least one of those attributes has a numeric value and therefore a potential threshold, a level at which a change in that attribute exactly offsets a change in another attribute. So in this particular example, the researchers were comparing warfarin to no blood thinning medication. And in the same study, they also compared aspirin to no blood thinning medication. And they start with a baseline of no treatment on the left-hand side. That would be what we would call the reference treatment, the state of the world without treatment. And then they provide an alternative, or the target treatment, where in this particular case, there is a reduction in the chance of major or minor stroke over the next 10 years. That would be the benefit, but it also comes with an increase in the risk of bleed, which are the red frowny faces at the bottom. And then depending on the answer to this question, whichever they chose, we would increase or decrease that number until someone was indifferent between the two, which we would see by the way in which they switched from one choice to another. And that would tell us the number of severe bleeding events over the next 2 years that exactly offset that reduction in major or minor stroke. And we would do this by, this is how the back and forth choice questions would come at the threshold that these people would actually get to, and each individual has a threshold, and then you can summarize over a sample. And in this case, this is just a plot of those results showing that, among patients, a majority would say that I would accept an increase in the rate of bleeds if you reduced my probability of stroke by 1 out of 100 over the next 2 years. and that I would be willing to accept lots of bleeds, 22 excess bleeds, in order to avoid one stroke. An alternative, which is not that dissimilar from the threshold technique, is modified swing weighting. So in a modified swing weighting, we take attributes and we say, among those attributes, probably based on clinical data, what is the relevant change or the relevant difference between two alternatives? So in this particular case, this is a pilot study in oncology, not related to a specific product, but looking kind of on average at what could be expected for different oncology blood products or oncology products in myeloma and melanoma, that the typical outcomes would be increasing survival or the probability of living 12 months from about 45% to 65%. Decreasing the probability of having moderate toxicity and decreasing the probability of having a severe toxicity. So once we have those, we ask people to rank which of these changes from the baseline is most important. And then we take the first and compare it to an alternative. So in this case, we take the smallest probability of survival here on question 1 on the left-hand side of 45%, and we say, hey, if we can increase that to 55%, what would you accept an increase in severe symptoms or adverse events in order to offset that? And then depending on what the person says, in this case, if they say, no, I wouldn't accept that, we can then ask them, well, would you accept that if we had a greater increase in the probability of survival? So we would vary the benefit until it exactly offset that increase in risk. So in this case, the authors looked at preferences from healthcare providers, patients, caregivers, and advocates, and regulators. And what we find is when we look at the trade-offs that patients are willing to make, that gives us the relative size of these 3 different swings. We find that for each of the groups, overall survival is more important than avoiding the risk of severe toxicity, is more important than avoiding the risk of a moderate toxicity. And so that pattern is fairly consistent over all 3 groups, even though the relative sizes are different. But what is particularly interesting in this study, and I think demonstrates a key point whenever we talk about preference methods, is if you look at the shot on the right here, which is a diagram from this study. That red dot there, kind of in the upper right-hand side, or maybe it's in the middle of the right-hand side, that represents the mean of what we see on the left-hand side here for one of these groups. But you can see when we plot out all the individuals, the trade-offs they're willing to make among these 3 different attributes, we find that for each individual, that result is all over the map. So that mean is a mean, but it doesn't capture all of the heterogeneity across all of the different people in the population. So one of the things that this reminds us of that we always need to keep in mind is that preferences, we assume, are heterogeneous, meaning that if you and I look exactly the same on paper, our choices are not necessarily going to be the same. And they could in fact be quite different. So whenever we talk about preferences, we need to look at the heterogeneity in preferences, of which there appears to be quite a bit in this study. So another type of study would be best-worst scaling. And in this case, there are 3 cases of best-worst scaling: case 1, case 2, case 3. I'm going to present here case 1, which is the object case. So in the object case, we have items, and each of those items is an attribute or outcome. Unlike a DCE, unlike the threshold technique, unlike modified swing weighting, I'm not concerned about the rates of these outcomes per se. It is the outcome itself. Is it there or is it not? So in this example here, where we're looking at different symptoms of psoriasis and psoriatic arthritis, We have 1, 2, 3, 4, 5. I meant to check this out. I think we have 20 symptoms overall that are captured here in this study. And what we want to do is understand what is the relative importance of each of these different items, these different symptoms and signs of psoriasis and psoriatic arthritis, without necessarily looking at the trade-offs that people are willing to make. So in a best-worst scaling, in an object case best-worst scaling, the items are broken down into smaller segments according to an experimental design where there is a subset among which you choose the best or the most preferred or the worst or the least preferred among that set. Then you have another set, and it's like sampling with replacement, even though it's not a sampling method, because there is an experimental design behind it. But just like in a DCE, you have a series of questions, and over that responses to the series of questions, you can begin to get these estimates of relative importance, where you can see that painful skin is the most important symptom to avoid, difficulty choosing clothes because you want to avoid things with buttons, or clothes that are too heavy or tough on your skin is least important, and everything else has a rating or in between. So two examples of why this matters, because so far we've just shown examples of interesting studies without really looking at the applications of them. But there are two examples of studies that actually had some sort of influence that I think are worth noting. And both of these happen to be in regulatory contexts for FDA. But there are examples of these studies having impacts in other areas as well. I'm just using FDA as an example. So in the first one, FDA did a stated preference study using a discrete choice experiment for obesity devices, and then created a tool using the results of that study to which they could input and apply clinical data to estimate the proportion of the population who would choose that particular option over no treatment. And that was published in surgical endoscopy in 2015. In the example on the right, which is a very different example, Genentech had rituximab in two different formulations. One was subcutaneous, one was intravenous, for blood cancers. And they had established the bioequivalence between the two different formulations. And their research question was, which one do patients prefer, subcutaneous or intravenous, all else equal? And they were able to get the all else equal part because they had already established the bioequivalence between the two formulations. So they did a crossover study and then asked which of these patients would prefer after having been exposed to both and after controlling for randomization and those types of things. So the obesity study, which used the DCE, was actually used in a regulatory decision. So this technology, and I know actually nothing about this technology, but this obesity device, this V-Block Maestro system, came to FDA for review. It did not meet its primary endpoint in its clinical study, yet it was still approved. And one of the reasons it was approved, according to FDA, was that the FDA survey for obesity, when they used the tool and assessed the clinical data, demonstrated that there was a group of patients for whom the benefits would outweigh the risks. And that group of patients, if you extrapolated that to the overall size of the US population, was probably a pretty big number of people. So in other words, there was a population out there who could benefit from having this device available, given the clinical data that FDA had at the time. So that study was used to support that decision. The oncology example was used in a very different way, whereas in fact, it wound up in the label. The results of this study wound up in the label under the patient experience data subset. And remember, patient preferences is one type of patient experience data. But it actually, the results of this study saying that the patients preferred the subcutaneous formulation to the intravenous formulation wound up in in the label. And to my knowledge, I think it's the first time, certainly one of the very few times, if not the first time, that patient experience data has actually shown up in a project or product label. I should say patient preference data has shown up in a product label. So even though it's not commonplace, this demonstrates that this stuff can happen. And one of the things I want to point out, though, is how this got into the label, I think often that's the holy grail for drug developers, is getting something in the label. And I think in this particular case, it got into the label for a couple specific reasons that you don't find in most preference studies. The first is this was an interventional study. So patients actually had the experience with the options that they were being asked to evaluate, as opposed to a hypothetical study where we asked people to tell us what they would do in a hypothetical scenario. The other thing is, in this case, as I mentioned before, this really isolates that single attribute mode of administration, because they had already done all the hard work of making the all else equal a reality by demonstrating bioequivalence. The other thing that this study showed was stability in the preferences. They actually asked this preference questionnaire twice, once at cycle 6 and once at cycle 8. And in each case, they had very similar results. So they were able to say, this wasn't a fluke, these preferences are stable. People, when they tell us that they prefer this thing today, that doesn't change overnight or due to the weather or anything like that. And finally, the results here were completely unambiguous. 77% preferred the subcutaneous over the intravenous. So it wasn't as if this was a small subgroup who thought that the subcutaneous was better. This was a pretty large majority of patients. So we've sort of done a very quick tour of patient preference information. So just a couple closing thoughts, if this is all you take away from this presentation. And the first is, patient preference information is a very specific animal. It has a definition. It is different than other measures. So it's not a nebulous, poorly defined concept. It can be used as an input into other processes or measures like MCDA or quality adjusted life years. And finally, there are many tools in the toolbox and many uses for this information. So even though there are a certain set of methods that tend to be used more often than others, there are a number of methods out there, and you'll see a couple additional examples as we go through the afternoon. So I think at this point, I will pass it back to Nora.
Thanks. I think, Brett, we have a few questions for you and for others on the moderator board. Caleb asked, is there a useful chart or reference? Oh, oops, there went my chat. Is there a useful chart or reference? Well, that's all the way down here. For PIs to help guide ideal tools to use in developing a study?
So there are good guidance documents out there. And I would recommend starting with the task force reports from ISPOR. There are 3 primary task force reports, and they are one from 2011. John Bridges was the lead author on that. We refer to that as the checklist. That's probably still the best outline of how to approach a stated preference study. The second is on experimental design, specifically for discrete choice experiments. That one was led by Reed Johnson and published in 2013. And then the third is on statistical analysis in discrete choice experiments that I had the privilege of leading in 2016. All of those are published in Value in Health. There are also a number of literature reviews out there on best worst scaling and threshold technique and discrete choice experiments. And those literature reviews are actually incredibly helpful and were to me, and I think I've heard that they are helpful to others, to give you an overall sense of the properties of the methods. So I would recommend looking into those as well. And I guess maybe, Nora, we can get some of those up in the chat during the rest of the session here. Those are really good starting places. There are a couple really good textbooks out there as well. We can give you some of those references. But I find myself starting with the ISPOR Task Force report from 2011 to give you sort of this overall view, and then looking primarily at the literature reviews that have been done using the different methods. Those are great starting points.
Great, thank you. Yes, we'll provide those resources. In the chat, another question in the oncology from Michael, in the oncology MOA example, why did the manufacturer conduct the PPI study and care about having the results in the label? Did they only want to patent one of the two methods?
So they were, I don't know all the details. This was a new biologic license application. So I imagine there were patent issues for this particular formulation. So certainly demonstrating the strength of preference for the new formulation would help in that case. That's all I know about the specifics of the motivation behind it. The clinical or the studies that have been published on that have been with regard to the trial and the methods, not so much around the motivation.
Great. And one more question from Hadley Smith. Are you aware of any methodological work regarding translating DCE results to a QALY or similar for use in cost effectiveness analysis?
So it's interesting. I had a conversation with some colleagues on this exact point yesterday. You know, we've thought about this for a long time, and I think, so the answer is no, not really. Not anything that's even near ready for prime time, because what we're estimating when we look at a DCE really are trade-offs among attributes that we could put back into health states or profiles. But outside of something like an EQ5D, where you have that time dimension, where you can sort of calibrate death by knowing what people are willing to forego in terms of life years, it's a little tough to do a traditional health state utility in a using a DCE. It's very easy for us to get a profile that looks like perfect health. You know, we can have no symptoms, total cure, everything could go to zero, as it were, in our profile. The problem is, how do we get a profile that looks like death? You know, because we can calibrate in a DCE between our best case and worst case scenario very easily. And again, we can get that best case very easily, but you know, what is my level of, you know, performance on an attribute when actually my health state is death? That's, in my mind, the fundamental issue that doesn't allow us to take what is essentially an ordinal measure and put it on a cardinal scale between 0 and 1. However, I am aware that there is some calibration work being done, but it's not ready for prime time. I think it's pretty exploratory. So this comes up every year as a topic, and I don't think we're much closer to an answer. So sorry to disappoint.
Thanks. I think we have time for one more question from Anton. Anton asks, is provider-induced demand or provider-induced preferences a concern when measuring patient preference information?
So in the real world, I don't think it's as much an issue of influencing patient preference information, because typically, especially when we do studies of preferences in hypothetical settings or with hypothetical choices, the provider's not part of the equation. You know, part of the reason we do it this way is because we want to get to patients directly, understand the trade-offs that they are willing to make without the provider present. Because we know that once we, you know, the patient, the decision itself is not something that the patient makes themselves very often, particularly, well, with any kind of treatment. Not only do you have the provider involved, but you also have the payer involved, because that limits what's available to you. And in fact, in the broader level, you have the regulator involved, because they even limit, and rightly so, I don't mean that to be pejorative, limit what's available to even be reimbursed, let alone then what is reimbursed, let alone what is then prescribed. So we try to do patient preferences totally outside that actual real world decision context in most cases. Particularly when we're doing sample level estimates like with a DCE. So we do it to get specifically at the patient preferences without these other forces. So the advantage is, we believe, we get something that looks more like what is representative of the patient's views. But in doing so, we are further away from the actual interactions that occur at the treatment decision. So that's somewhat of the trade-off that we make, so that often some of this patient preference information stuff that we get is not useful necessarily in a shared decision-making context, because we are looking at the patient perspective from a sample level, when the reality is very different when you're looking at specific choices at an individual level. There is some work that I'm aware of that is being done to look at patient preferences in an observational setting, where first patient preferences are elicited before the conversation with the physician, then they're elicited again after the conversation with the physician, and the objective is to understand, can we learn from that what the influence of the physician actually is? So we try to avoid that situation, but in doing so, we abstract from reality a bit. So I think we're now trying to understand how that mechanism actually plays out in these types of data.
Great. Thank you so much, Brett. I think at this point, we will move on to John's section. John?
Thanks, Nora. And hi, everybody. Happy to engage on the chat. It's a little bit hard to present and chat, so I'll leave the others to answer, and I can come back to questions. I'm really thinking about some questions that are kind of popping up at the moment. It is this notion of designing the experiment, and then does this happen at the individual level or at the aggregate level? And there is a continuum, and what I want to do is show you that continuum and show how experimental design issues might apply to some of these things. So I really am focused on that experimental design. One of the big take-home issues with regards to this is this difference between designing an experiment that is statistically efficient, that is parsimonious, small n, tight standard errors, and respondent efficient, and that is getting the respondents to tell the truth. And we can have different notions of truth, but some of the tools that we might use may cause people to say something that we might clearly observe as not being the truth. And we're going to pick up a little bit on that. And we're going to look at some different types of designs and see how we can actually make some experiments work. We are trying to abstract from the real world when we measure many of these preferences. Brett showed that a couple of these are what we might call revealed preferences, but many of them fall into experimental and non-experimental approaches to measuring the stated preference. We can also think about guiding towards values or opinions or other types of frameworks, depending on what type of question we ask when we present the task. We're really trying to think about a procedure that is logical, can be repeated, can be tested. Issues of internal and external validity may happen. I'm not necessarily going to answer the question, are they targeted at the individual or are they targeted at some form of aggregate? But issues of measurement bias and heterogeneity apply across that continuum. And so we can kind of see the role of this in a number of different ways. And I'm going to show you individual and aggregate results in a second. So when I first got involved in this, I was also very interested in causal mechanisms, and particularly the randomized control trial, either getting a treatment or control, trying to assess some outcomes or potentially multiple outcomes, and then, you know, really trying to get the confounders to be balanced or trying to be orthogonal to the experimental stimuli. And that's, you know, and one of the nature of experimentation, particularly when we're dealing with humans. Before we get there and do those types of experiments, you know, we have our kind of T0, T1 types of science that helps us gather theoretical models, prior empirical models, and previous experiments that allow us to get into these experiments. When people first started doing stated preference work, I think they were just very happy to start a survey and get it out into the field. And I think what we've realized is that the types of experiments and methods that we're using also need theory, prior empirical models, previous experiments to be able to think about that. And there are a number of different frameworks that are available now that talk about the foundations of making one of these experiments. So we kind of know that the notion of now generalizing to a 2x2 trial. Imagine that we had treatment A and treatment B, then we could have 4 arms in a trial. This is wonderful because there's some more hypotheses and observation that we can be able to get into and kind of understand these stimuli and their effect on some predefined outcome. As we start to get into bigger experiments, you know, we can think about 2x2x2s, or that 2-hat-6 is actually one of the first experiments that I got into. Jordan Louviere and colleagues published work in the late 2000s and early 2000s, late 1990s. That's when I met Jordan Louviere, one of the people who kind of was prominent in the field. And I found this little experiment, it was some of the first preference work that I did, and I still continue to use this experiment. And I'm going to show you it in a second. And I still continue to use that in my research. But as we get to greater complexities, the experiment that I quite often use is somewhere around that, you know, if we follow that good research practices document that Brett alluded to earlier, it says that, you know, when you're doing this type of preference trade-off, it's maybe ideal to have something like 3, maybe 4 attributes with, you know, 5 to 7 levels each. So even if it was like 3, we're considering 253 states of the world. If there were 5 levels each, that 4-hat-6, now we have 1,000 states of the world. And these are starting to get into greater levels of complexity. You know, like in engineering, we use these types of methods to work out how to make best steel, and we have all the different combinations and test the strength of the steel by making many different types of steels, quite often 16 or 32 different types of steel. But sometimes in health, like if we were thinking about all the different possible ways that we could approach secondary prevention in somebody who is recently diagnosed as pre-diabetic, and the different aspects that you could kind of do in there. There are many different ways that we could approach that, and each one of those has many realizations of what we might consider as levels. And so whilst out in the real world, there are some experiments that have some variation that the real world has. When we start considering all the possibilities, we really have to go to this simulated world to kind of think about these n-dimensional studies. We of course can't go and test all of those experiments. If we've got 1,000 different policy options to provide diabetes management or pre-diabetes management, we can't go and try 1,000 different options in a 1,000-armed randomized control trial. But we would like to get some insights maybe on a couple of those different dimensions. And so we can kind of simplify the experiment by looking at, so for example, experimental designs that just focus on the main effects of these components. You know, when we start to have hypotheses that generate a large number of interactions, once we start putting multiple interactions on the board, then all of a sudden we are heading towards an experiment where we actually have to go and consider all 1,000 states of the world to be able to estimate all of those interactions. So I'm want to kind of bring us back to this Occam's razor that, you know, we are building a simplification or a parsimonious view of preferences. And, you know, I quite often like to remind people that, you know, we're making models of the real world, and, you know, one wouldn't expect a model ship in a bottle to have a working galley. You know, but it looks like, you know, it's a representation of what a ship would like, but it's not a functioning ship all the way down to the nth degree. And that's what our preference models also have. We want to put main components in there, and theory and practice gives us some identification on how we should design this. But we also want to keep these experiments simple. And kind of since I've started presenting this type of work and thinking about this, the dimensionality of my experiments are getting smaller and smaller and smaller. Like some of the first best worst scaling case ones that I did had 16 objects in them. The last couple that I did only have 7 objects in them, to kind of really simplify down to a smaller number of dimensions. My discrete choice experiments, 3 to 4 attributes, up to 7 or 8, 7 to 8 attributes with 3 or 4 levels each. Now, if someone walks in the door and I say, I'll do that, but I want 4 attributes with 3 levels each. If you want something more, go and hire Brett's group, because they're much more capable of doing complicated designs. But you know, I only have a fixed number of designs that I want to play with these days, because I don't have a big design shop to be able to go and use computer simulations to be able to go and identify ideal experimental scenarios. So, you know, let's go back to this 6 attribute world. And we can kind of think very basically about 6 attributes that would have 2 levels each. And there's a couple of different ways that we can think about this. Present or absent, this generates what's traditionally been called in the literature a 2 to the k design, because there's k objects and they're either present or absent. I've played with a couple of those designs, but more realistically, we kind of like, you know, the levels might be medium and high, and, you know, or something like that, and we can have up to 6 experiments. And this is a very simple way to do that. So, you know, some of the questions that we might have is a full factorial here generates 64 possible combinations. That's 2 to the power of 6. What would we need to do? Do we have to assess all of those? And for example, I could get a card sort and ask somebody to put all of those 64 out and rate, you know, put them in order. You know, we might be good at the top of the pile, but we might be good at the bottom of the pile, but certainly in the middle of the pile, I don't think that we would be very reliable in internal reliability. And so there'll be sources of heterogeneity that experiment is going to be complicated. So can we simplify this down? There's a couple of different ways that we might be able to do it. Do we have to go to having an experimental design? Could we go to some simple profiles? And for example, there are a number of methods out there, swing weighting, where we could look at the difference between the 2 attributes and kind of like say, hey, when we consider the 6 attributes, what's the biggest difference between their levels? You know, which attribute has, you know, we could look and say there's probably a more desirable and a less desirable on each of those attributes. Which one has the biggest difference? And then we could kind of go down and have a look at them. We could do some ranking. We could look at people's willingness to accept or purchase the different attributes or different profiles. We could do that at the attribute levels themselves, but we could also do that at the profiles. So one of the kind of things is, do we want to work in univariate space and then kind of combine a theory of value that sums up to the profiles? Or do we want to start with the profiles and then kind of decompose the scoring, the rating, the ranking, the purchasing, the budget allocation, whatever preference elicitation method that we have? What could we do? Given Brett's definition about trade-offs and the relative acceptability or willingness, when we consider that, one of the things that we might do is look at these profiles and try and generate an elicitation mechanism by which there has to be some forms of trade-off. So if we started printing these out on individual cards, people might have to, and we said, if this card was real, would you accept it, yes or no? Then people might have to see on that card that there are some good attributes and there's some bad attributes, and then they have to consider on the weight whether the good things outweigh the bad things. One way to kind of do this is the experimental design that I found in a textbook. And so, you know, it looks a little bit strange when we first come to it. You could actually find this experimental design in most statistical packages now. Most statistical packages are going to have what we call the catalog designs. But I found this design early in my career and I've made a lot of it. Some observations on this design. It's like some computer program, it's ones and zeros. There are the 6 attributes, A1 through A6. And this experiment has generated, from the 64 possible combinations, it's highlighted 8 of the combinations that have some interesting properties. If we look at A1 here, we can see that the realization of attribute 1 is 4 times 0 and 4 times 1. So it is across this set of experiments or set of profiles, we would consider that A1 is balanced, that it doesn't have a predisposition to have one of the realizations or the other. The interesting thing about this design is that goes for any of the attributes. If we look across any of the attributes, they are 4 times 1. So in A2, we've got 0, 0, 1, 1, 0, 0, 1, 1. We can look at this, and so many people over the years where I've presented this go, there's a pattern here. I can obviously see a pattern in this design. There is a pattern and there isn't a pattern. There's only so many different combinations that you can do. In 8 runs, actually for 6 attributes, we couldn't get any less runs and maintain 2 key properties of this. The first one is the attribute level balance. And then the other one is that the realization of A1 is not predictive of A2. So look down and look at the ones in A1 and then kind of do a little regression in your head. We've got 1, 0, 1, 1, 1, 0, 1, 1. From like even a Bayesian point of view, having the information from A1 gives us no information as to what the realization for A2 is going to be. So if we had one of the pieces of the puzzle, so we come across and one of these runs, A through H, is on the table and we see some of the data, we're not going to necessarily be able to predict the rest of the data. Even if we had say, a number of the first observations, we wouldn't be able to go in and predict all the other observations, because as we kind of go across, it continues to be shuffled. This experiment is interesting because you can actually put a 7th attribute on the back end of this. It's an experiment. When people, after I used this experiment, sometime people turned around and said, what happens if I wanted to do a 7th? And I turned out, looking up the SAS catalog, that there is a superset design for which a 7th column could be added to here, and we could identify 7 attributes with 8 runs and still maintain these key design principles. So let's start thinking about a design that we had. It was mentioned earlier about this intersection between quali land and preference land. So I'm going to use an example that Brett mentioned, the EQ5D. But the EQ5D has 3 levels or 5 levels, but my starting experimental design, you know, the one that I used for a great deal of my career, only has 2 levels. And so I'm only going to put 2 of those levels in here. And in some respects, parts of it kind of look like that 2 to the K design, that either some impairments are present or no impairments are present. And I can make an argument to say, oh, I didn't put the 3rd level in because I might have got some implausible combinations or some rare combinations, or in the general population, the vast majority of people are up in this space. There are very few people in the general population that have too many 3s or multiple 3s in their profiles. So as my analogy of the ship is that, you know, hey, this is a model of the world, and if I could make an experiment of it, so using the array from the page before, I could generate 6 combinations or 6 cards of this stimuli, and think about this. So what could I do with those 6 cards? I could ask, how are you on these 6 cards using a visual analog scale? I could use the visual analog scale from the EQ5D, the 100-point scale. I could go and do a standard gamble or a time trade-off on these profiles and get a quali for my 8 profiles, and then use some regression techniques maybe to go in and impute the rest of the values. The original EQ5D study that was done in the UK did something like this. They used a type of conjoint analysis where they made some profiles and went in and didn't ask all the possible combinations, but asked a number of them, and then used regression techniques to go in and fill the rest up. I could do some ranking, so I could ask somebody to sort them into from best to worst. I could do nominal group technique and try and think about bucketing these into like bundles, so I don't have to do a quantitative approach. I could have used a qualitative or basket sorting type of approach. The other aspect of it is that I could potentially use a take it or leave it strategy. Maybe not good with the profile, because it's pretty hard to work out what the counterfactual is. Although some of the methods that I've been using, I've got dogs. Dogs, go get out. Can someone get these dogs? Sorry, this is the problems of working from home. So another thing that I could potentially do in addition to a take it or leave it, so this is one of the single profiles. Another technique kind of talks about, rather than just taking or leaving this profile, is basically saying what is the best aspect of this profile and what is the worst aspect of this profile. And I also have to note that I added some time onto this design to look at some trade-offs here, because I'm going to show you that in just a second. we could have come in and looked at this. Let's just skip that. Here is another type of design. Here's a paired profile. Because there are only two profiles, if you have a piece of paper handy, I'd like you to kind of like just jot down this. This is going to be like the eye doctor, which is better, option A or option B. But here we've encountered our first conjoint analysis or discrete choice experiment that we're all going to kind of have an opportunity to do. So if these two states of the world were real and you had an option to live in one or the other, and notice that they've got different degrees of morbidity and then a different lifespan associated with them. We can have a look and kind of like say, if these two options were real, which one would you take? You can kind of see from that first experimental design where it was kind of like all zeros or all the lower levels, and then compared to all the higher levels, we can kind of see that there is a straight up, longevity versus disability trade-off here in aggregate. But that came from our experimental design. We could have done some effort to try and get rid of this problem, but I actually think that this is a very interesting question. Some people look at this and go, oh, there's an obvious answer. But I remember a couple of years ago when we did this in St. Louis, the majority of the people in this class were oncologists, and they went 10 years. That's a lot of years to be giving in oncology when they were at that time dealing in months. And so here the trade-off for them was not very interesting. So I like this task because everybody thinks that everybody else will have the same answer. But when we've done this empirically, and I've done it with maybe 1,000 different people, there is heterogeneity even with this task. So that's the first task. This is the second task. There's going to be 8 of these based off the 8 cards that we have had, and we can kind of work through these. Generally, we would have, put this in a computer program and put some additional information in here. We would have some background or discussion points that made sure that people understood what, these are shorter labels. We could go in and potentially elaborate on what this means and what it might mean for functioning, or for the need to take additional medications. And so there are a number of different layers that we could have put on before we had this type of experiment. And we can kind of go through and see these different cards. Because when we used to do this and there was only 8 people in the room, I would get people's answers, but I'm going to kind of skip through this and kind of think about the different designs. You could generate this experiment yourself from the experimental design that I presented earlier. But, there are a couple of different questions here. Did the tasks, on the statistical efficiency, was that a good experiment? Did it allow us to tell the truth and be according with our preferences? It may potentially have generated some simplifying decision rules. If when people go through and think about this, we can kind of think about some issues there. How much error was involved? Would people get tired with these? How many of these questions could you possibly answer? This experiment, because it's orthogonal and it actually is a minimum orthogonal. So one of the consequences of being minimally orthogonal is that it had 0 overlap. And so one of the issues there is there was no, if there was just one attribute that you wanted to do, let's say that you were Machiavellian and you were an advocate for anxiety and depression, you could always vote with the anxiety and depression and kind of convey that piece of information, even though you probably do care about the other attributes, but you were just really trying to say about one answer. So these results come from an SMDM conference that we did about 3 or 4 years ago. And these are the regression results. They just happen to be in ordinary least squares. I've got 7 parameters and 8 observations. This is a single person. And when we look at this person, things are really looking good. increases in life expectancy have a positive utility, and all of the increases in morbidity are associated with a negative utility. The R squared is really high. Comes from an individual respondent. So we would say the internal consistency was quite high for this model. This model would do a pretty good job in predicting the choices that are out there. We also have a statistically significant outcome. And so it's quite exciting. We're off to the journal because we've got a p-value that's significant there, or a t-test that's above our required threshold, even accounting for the very small, like even if we not did it on a z, but did it on a t distribution because of the small sample size, we can kind of look at it. So it's just like, oh, this is a great tool and I want to use this all the time, and I could use this in the clinic, I could use it in a number of different ways. And then we see this person, and we kind of like go, well, this person was a lot like the last person. They're telling me about anxiety and depression. And, oh, hang on. We see this kind of change in monotonicity on mobility. So this person prefers to have limitations on mobility than no limitations on mobility. And so that's a bit of a strange result. It's not statistically significant, but when I look at the face validity of this answer, it has a lot of good characteristics, but there's kind of like this one question that kind of says, I don't know how valid that is. Remarkably, this type of answer comes up a lot. I always described this as my kind of like standard student. I don't know if I attract people that have anxiety and depression, but when you do this against a younger cohort versus an older cohort, anxiety and depression really shows up a lot more than the self-care and mobility. Maybe that's because they're a university student and they don't have to be very mobile or care for themselves that much. Well, what about this person? All they care about is self-care. So, maybe you've met one of these people in your clinic or in your research or in your focus groups, and they're saying something pretty strong here. One of the problems with this answer is that it's non-stochastic. If we see there, the R squared is 1, so there's no statistical variation here. That means there's no standard errors because this is a deterministic model. We always know how this person is going to vote, and they're always going to vote for the better option on self-care. And in this one, they always want no limitations on self-care. So is this person protest voting? Are they voting strategically? Has the experiment accidentally tricked them into doing this? Maybe, like, I've seen this answer and then the person turns around and says, all I care about is anxiety and depression. And then I show them these results and I was like, no, you don't. That's not what you were focusing on. And so in that instance, sometimes we can think about a task, even this simple, as sometimes being preference revealing, even to the subject themselves. It could help them understand what it is that they were making trade-offs over, or here the lack of trading, and really determining what motivates them the most. When I bring all 5 people that happen to take this course together, these were the aggregate results. Kind of looks good. See, the standard errors are tight. This is a statistically efficient. That's for this particular experiment, that's the smallest standard errors that you can get because of the very immaculate experimental design. But there are still some potential issues with this experiment. One, look at the variation. I think somebody noted before I started speaking about individual heterogeneity versus aggregate heterogeneity. Now, we want some heterogeneity, otherwise we can't use theory and statistical methods. So that R squared in the 70s, 80s, and 90s, I think was a reliable way of making a model. Here we might say 0.52, that's not very reliable, but does a reasonably good job. if we sat down and thought about this within a particular group, it does a reasonably good job. In the aggregate, that life expectancy is quite valuable. You know, if I have 5 people answer 8 questions each and get statistical significance on 4 of the attributes, all the attributes are pointing in the right direction. You know, there's still a lot potentially kind of going on here. Here, I'm just going to come in, and that person 3 that we saw that was voting in a strange way, we're going to kind of correct them, and we can see that the R squared comes up. So that person who was only focused on the usual activities, we're going to change some of their attributes, take them out and just replace them with someone who's more standard, and the R squared can go up. If somebody came in and just didn't really care about our survey and just put 1s, you know, option A, 1A, 2A, 3A, 4A, and put 1s down there, we would see here that our validity would go down, because really that person's responses are orthogonal to the stimuli. And so we're going to get a lot more variation. Our standard errors went up. Our statistical efficiency, our ability to make statistical inference went down just because one person wasn't paying attention. That can be a problem. So here, when we kind of think about our different models, generally they're kind of the same. They're not way out from one another, but they would lead to some potentially different types of statistical inference. They have different R squareds. And there are some subtle differences here, but we've played around with trying to do some sensitivity analysis or worst case scenarios on this. But how people answer, it's not just the experimental design, the underlying experimental design was the same. It was the most statistically efficient design that we could have, but it relies on people actually making trade-offs, people looking at all of the attributes. Sometimes we have an attribute non-attendant. So imagine that I came in here and I just happened to put anxiety and depression a second time into my experiment, maybe with a subtle difference, maybe exactly the same. Some people might focus on the first one. Some people may focus on the second one, but I don't think people would focus on both of them at the same time. And so here that could lead to a situation which is called attribute non-attendance. And that can be a problem. If somebody doesn't attend whatsoever, we can have increased heterogeneity. Sometimes we have that, particularly when we're using third-party vendors to generate samples from the public, for example, and they're getting paid and they don't really care about our survey. So we want people to care about our survey. We want them to buy into what's going on. We want to understand them. There's a number of different ways that we could potentially do that. The other aspect here is there's probably some easier ways to do this. We were looking at trade-offs and we went, oh, maybe a discrete choices experiment is better because it makes trade-offs, but it doesn't enforce trade-offs. Because of the experimental design, people can non-trade off or have lexicographic, so they'll focus on one attribute and only focus on the next attribute when that attribute is fixed across the profiles. And so another way is in some questions, like if we were just trying to say, which of these should be our primary endpoint on a clinical trial, there may be some other types of designs that we could have come by. The 2 to the K design. This is an example of the 2 to K design. I've used this in Africa where we were kind of using translators and we wanted to kind of simplify the experiment. This is interesting and I've used it several times. But one of the questions here is, do people just count the number of things? Well, some of these things are positive and some of these things are negative. So we're still making them trade off. But it's simplified the amount of text here, maybe still keeping the same amount of information. But one of the problems is that the cell sets are not of the same size. And so best worst scaling was invented as one way to kind of do that. This is a best worst scaling case 1. Sometimes it's called max diff or object scaling. And basically, one of the things that we can do there is use what's called a balance incomplete block design. Sometimes they're called a Uden design, but all Uden designs happen to be balancing complete block designs as well. But there are the designs, you can find these designs in Stata and in other programs. And basically what we can kind of come up here is have a workable number of sets, have the sets show up. You know, we don't want to have, there's not necessarily orthogonality here because we're thinking about a different focus. But when an object shows, we wouldn't want it to be shown more or less with another particular objects. There's an ideal number of objects per set size. So this happens to be Uden 6.6.5.4.4. Okay, there are 6 attributes. There are 6 tasks. There are 5 tasks in each run. Each object is shown 5 times, and the overlap is 4 times. So B is shown with all the other attributes 4 times each. It's a pretty simple experiment because you can just see in this experiment in run 1, A is missing, run 2, B is missing, run 3, C is missing. So we've made a pretty easy experimental design out of here. There are some nicer experimental designs that appear for these types of experiments. There are catalogs. This is a set that I use, but a lot of these experimental designs are available. I just happened to use the 5-10-4-2-1 recently, and that was interesting. And so we can kind of think about it. These are the ones like I mentioned, I started using the object scaling with 16 attributes. Now I'm 16 objects. Now I'm getting down to that 7 to kind of like minimize the number of tasks and then minimize the number of profiles. When we wanted to think a little bit about the complexity, so a lot of people quickly come to me and say, "Oh, John, you're an expert in discrete choice experiments. Conjoint analysis, discrete choice experiment. Best worst scaling is a type of discrete choice experiment where 3 or 4 or more profiles are shown and you just show the best. You ask for not only the best, but you might ask for the worst. You might ask for a complete ordering. But imagine that we had 3 objects, 3 attribute levels, 4 attributes, and you know, we were trying to get that 2 to 3 profiles in each task. When we kind of come down here, you know, if we had 6 attributes with 3 attribute levels in it, these are the number of tasks. But what happens is that's just a single task. So there are 729 profiles. But if we made a conjoint analysis, we'd want to make a pair of those. And so that means that there are 500,000 possible pairs that we could generate. If we were making triplets, there are 387 million possible triplets that we could have made. And that's just one task. If we were using, say, that best worst scaling case 3, let's even look at that 282 billion possible single profiles that I could generate using 4 profiles each from this basic experiment. Well, to make a statistically efficient version of that experiment, I probably would have to make 20, 40, 80 of these such profiles. So I'd have to raise this number again to the power of 20, 40, or 80. And so we can understand that, you know, these numbers start to get really, really complicated, and we start to approach higher levels of infinity with regards to the number of ways that we can make these experiments. And so whilst, you know, a lot of people come with complicated questions and a real desire to do discrete choice experiments or higher order multiple profile tasks, you know, I have to turn around and say, these are really complicated. And I can't describe to you enough of how complicated an experiment can get. And I know many people from the years have kind of come back to me and said, "Oh, John, I ran a complicated task and I'm running into problems with analyzing them." And what we see is, you know, sometimes some of the important statistical properties in making a workable number of profiles have gone away, and we have some real issues with the aspects. Here are some of the data. This is a little bit old, and I think a lot of this is just misreported, but we use a lot of different programs. At SMDM, a lot of people use Sawtooth. I think SAS now and Engine, a new program, is there. We want to think about, is the model that we want to generate identifiable? So if there are parameters that we need to estimate, does the experiment allow us to estimate them? That doesn't always happen. I've had plenty of students from this course come back and show me an experimental design where key attributes were not identifiable, just because they lacked their for example, two key variables were structurally collinear with one another, and therefore they couldn't be identified independently. The efficiency, obviously we want to do this with the least amount of tasks, least amount of people, least amount of burden. And here are some of the different considerations. We worry about the correlations amongst the attributes, the level balance, overlapping. Sometimes we want minimal overlap. That's not always the case. Sometimes a moderate amount of overlap may help us force people to make trade-offs, but it's going to decrease the statistical efficiency, which just means we have to ask more questions. There are a number of different efficiency scores out there, but higher is better. And so many people will report in the literature that they use an efficient design. And my question to them is, did you really check all infinity possible designs? Show me that you let a supercomputer search for your efficient design for many, many months. And then I might believe that you might have done that. But again, that's statistically efficient, maybe not respondent efficient. That perfect design may cause people to answer in a wrong way. And that's a problem. That's dealing with the cognitive difficulties and the other types of issues that do there. So the number of different designs there, or we talked about the report from Reed Johnson and colleagues that help generate that. But still, this is about one of the scariest elements of my work, is trying to find this. I love catalog designs whenever I could use one. There are a number of other different issues out there. The costs, so a lot of people come and say, I want to do this really fancy design. And I was like, great, I'll charge you, like $45,000 to get you an experimental design. And then we have to pilot that, maybe another $75,000 worth of piloting and cognitive debriefing to verify that it doesn't do it. And then they go, oh, but I need the results next week. And I was just like, well, we better make this experiment more simple. Here are some of the principles that kind of detail the different designs when we think about the available different designs out there. A lot of them tend to be the same. This latest one, which was the foundations of Engine, seemed to be quite prominent. But some of the real issues that we see in some of the earlier designs, like the Street and Burgess design, they're present, but just not as obvious in the Engine designs. And so there's an undercurrent of problems, but it's just not in your face problems. So I can leave it there. I'm not sure where we are, Noni, in terms of time and the availability of questions. I saw some pop-ups of maybe 18 possible things for that I could open the chat, but maybe you have some questions that you want to throw out to me.
Yeah, sure. So it is technically our break time, but I think based on the questions, it'd be helpful if we could just spend 5 more minutes. One question is regarding the kind of non-optimal experimental designs. So do you have any advice from Abram? Do you have any advice for modifying the choice sets after we are given an array from a computer? For instance, some choice sets need to be discarded if one has kind of all better attributes than the others. How do we do that without biasing results?
So when I use a catalog design, and I know other people are going to have a different opinion here, I never throw something out. What I might do is shuffle the starting positions. So a lot of my designs have this kind of catalog design. And then what I do is sort the rows and columns. It's still orthogonal, but in doing that, I can maintain the properties, but get rid of those silly patterns that one sees. And then the other aspect is you know, when I did my original profile and I put all the good things on one side and all the bad things on another side, I could have done some coin tosses there to kind of do that. So there is some randomization. We used to have what used to be called a lucky pumpkin in my office, where we, it was actually a Halloween pumpkin, where we used to just do some of this simple randomization to get our starting points. But sometimes we have some extreme votes. You know, so when I used that 2 to the K design, one of the tasks had 1 profile versus all the remaining 5 profiles, but it turned out to be policy a really important question, because it was basically the most important thing versus everything else. And that is a really good test of, is one thing better than 5 other things? And so we actually got some really good data for that. But when you start playing with experimental design profiles to maybe deal with the respondent efficiency, you're going to erode the statistical efficiency. And I've had some people come back and make some changes to a design such that the design is no longer identifiable.
Thanks, John. And from Ram, for statisticians and others involved in randomized control trials, we find no clear guidance on sample size and power in discrete choice experiments. Can you comment on this issue? And what about sample size and power for a particular number of attributes, levels, profile?
Okay, so there is some literature. Actually, the original Nobel Prize contribution, prize winning, I know it's an economist one, but by Daniel McFadden, did have a power calculation kind of built into it. There is an article in The Patient by Esther de Becker that kind of formulates that original sample size calculation from the McFadden work in using some very simple Stata code. So I'll ask Noni to maybe try and get the link to the PubMed citation for Esther's paper. I put it embedded into my question. So one of the issues is, in a randomized control trial, you have to hypothesize what truth is. And so you have to understand the possible effects. There has to be statistically meaningful results. And generally, we do other types of randomized control trials. We have theory, we have animal models, but I cannot go and do discrete choice experiments on pigs and rats and zebrafish first to identify how my model should run. I have to kind of go straight to humans, but how much piloting can I do? One of the issues there is the sample size calculation methods that Esther puts forward. You have to know all of the truths. You have to know the end result of the model. You have to know the internal consistency that people have. There are many different parameters that you have to kind of do. So generally, we kind of think of rules of thumb associated with this. Also, most of the models that can use calculated approaches focus on heterogeneity. So everybody has the same preferences. If you are, for example, wanting to estimate a latent class model, there is this question of, well, how many do you need from each potential class? So a class may only happen 6% of the time, but if we had generalizable national results, we might not have enough observations in that segment to actually estimate it with rigor. So maybe we would have needed to a priori oversample in a latent class. How do you oversample on something that is latent? And so generally more is better. And so, you know, my starting size, you know, some of the sample size calculations, Engine has a sample size calculator as well. Sometimes it'll spit out that you only need 50 observations. If I'm going to go to Gemma, I don't think that they would ever allow me to publish a preference study with only 50 people. So even though it might say I could do it with 50, I might go get a vendor to get me 1,000 people. I might be able to oversample on a couple of different populations such that I could do that and then use weights to kind of come back to it. But There are answers there, Ram, but they're not good answers. They require the basically perfect knowledge, perfect foresight, but so does a randomized control trial.
Great. I think we'll take a break there. It's 2:36 now, and we'll plan to come back at 2:45 for Ellen to talk about running through the analysis of a preference study.
Thanks, Nora.
Hello, everybody. I think it is time to get started again. My name is Ellen Janssen. Sorry, Nona, if I took your role here. Just jumped right in. My name is Ellen Janssen. I work at Janssen R&D appropriately. Have to say, unfortunately, not related to any of the originals. In this session, we were going to switch gears a little bit and hopefully make this sort of a hands-on experience as much as we can over this virtual platform. And I'm going to walk us through a preference survey and then discuss some of the issues with data analysis of a discrete choice experiment in particular. So one type of stated preference method. I am going to give you a little bit of an overview of the project that we're going to talk about here, so you have background and understand the survey and the data analysis we're doing. Then I'm going to briefly discuss how the survey was developed, walk you through the survey, and briefly describe the data analysis. This work was done as part of Project Transform, which was a partnership between researchers at Johns Hopkins School of Public Health and Ohio State University, as well as the Longevity, which is a large patient advocacy organization that advocates for patients with lung cancer in the United States. Project Transform was a larger scale project that contained multiple types of preference, for which we conducted multiple types of preference studies. And you'll see two of the surveys that were developed as part of Project Transform in this presentation. And what was notable about the partnership with Longevity is that it allowed us to make some, it allowed us to do some things in terms of development of the survey that were interesting and really a big advantage. In addition, the project was guided by both a patient advisory committee composed of patients with lung cancer and an external advisory committee, which was composed of clinical experts, policy experts. And these two groups helped us shape both the research questions and the surveys that were developed. The survey I'm going to be walking you through was a large-scale survey that was administered on a national level to Longevity's member database, as well as the member networks of two other patient advocacy organizations, and also a smaller sample from a market research panel. Because of the partnership that we had with Longevity, we were really able to do a very intensive survey development process, because we had access to lots of patients with lots of goodwill because they wanted to help the patient advocacy organization in their research agenda. So we ended up developing a survey through multiple iterations of changes that were tested with patients at in-person meetings. And we ended up conducting a survey that tested the preferences of patients with lung cancer for the short-term, the long-term, and the late onset side effects of treatment. So here is the choice task that was developed as part of the first survey version. This survey version was developed with input from the patient advisory committee and the external advisory committee, or the expert advisory committee, excuse me. And as you can see, it contained 5 attributes. It contained 1 benefit, progression-free survival, which could vary from 6 months to 18 months. Then it contained 3 types of side effects, one of which was with a severity attribute to short-term side effects, and then 2 risk attributes, long-term side effects and late onset side effects. And these risk attributes were described in terms of the percentage of patients that would experience a side effect, the side effect. So both in terms of percentages and then in terms of the number of participants out of 10. And then we included a mode of administration attribute as well. We, in the first version of the survey, asked participants to complete 16 of these choice tasks. So they saw 16 different versions, excuse me, of this choice task, where the levels were independently varied according to an experimental design, like, the ones that John described in the previous session. When we tested this survey, with patients, we found out a few things. One was that the maximum survival or progression-free survival benefit that we gave participants wasn't high enough anymore. So we were talking to a large group, or a large proportion of our participants were lung cancer survivors. And they said that, given new developments in lung cancer treatment, 18 months of progression-free survival was I wouldn't say on the low side, but it was definitely not, pushing the envelope anymore. So we increased the number of maximum months of progression-free survival all the way to 24 months, so 2 years. What we also learned was that for this particular population, so lung cancer patients can be a bit older, that having two risks was too much cognitively. So we changed long-term side effects to a severity attribute as well. And then one of the reasons we chose long-term side effects to do that and not late onset side effects is that participants also described that, it wasn't necessarily a question of if you were going to develop a long-term side effect. Most patients did. It was a question of how bad was it going to be. And then the risk effect that we kept in the second survey version was changed from a number of participants out of 10 to a number of participants out of 100. And this framing was changed because we heard that, having only kind of a pool of patients of 10 was too personal, and it made it less, it became, the risk attribute was interpreted less as a probability and more as a, oh, well, out of my group of friends, someone is going to experience this. Then the third, so we tested survey version 2, came back with some more feedback from patients. What I should say is we also found in survey version 1 that 16 choice tasks was way too many. So we had to reduce the number of choice tasks to 10. Once we tested survey version 2, we learned that the difference between 6 months of progression-free survival and 24 months of progression-free survival, so a year and a half of progression-free survival, was too much, and the participants really stopped trading when they saw a possibility of 24 months of survival compared to a possibility of 6 months of survival. So they weren't trading based on the PFS attribute anymore. So for version 3 of the survey, we changed it back to 6, 12, and 18 months of progression-free survival because we thought that that year and a half difference was too much. Everything else stayed the same, and we kept it to 10 choice tasks. Version 3 of the survey was not just qualitatively pre-tested with patients, it was also then quantitatively pilot tested. So we were able to conduct an interim analysis and see how participants interacted with the choice task and what the attributes, what the preference estimates were. And from that, we learned that really the feedback that patients had given us that 18 months of progression-free survival just wasn't cutting it anymore was quote unquote correct. So we had to go back and we had to think, how do we incorporate this increased amount of progression-free survival to 24 months without making progression-free survival the dominating attribute? And we did that by shifting the entire spectrum of progression-free survival. So instead of this big wide range of 6 to 24 months, we shifted the 1 year kind of variation in progression-free survival. We just shifted it over 6 months. So we went from 12 to 24 months. And then this was the final, the format of the choice task that participants were going to complete for the in the preference survey that I'm now going to show you. So could somebody chime in if they can see the PDF right now with the Johns Hopkins logo and the longevity logo at the top? Just wait, not your
That's
head.
fine.
Yeah, okay, just making sure. So this is a preference survey that we developed for this Project Transform. And one of the big things to remember when you're doing a preference survey is that you're not just literally throwing a discrete choice experiment or a best for scaling or a threshold technique experiment in front of people. You have to incorporate this as part of a survey. And in developing the survey, you need to follow general good research practices. So first of all, of course, you start with introducing your survey, the purpose of the survey, what the layout is, and then what participants can expect when they're completing it. You also need to include some sort of consent, depending on the IRB that you're working with and the sensitivity of the questions you're asking. We always include an example question. You need to include, of course, your screening questions, your inclusion and exclusion criteria. Then what we did in this survey, and we frequently do, is section 1 of the survey asked about the clinical and treatment background of patients to get a sense of what their experiences were. We frequently ask these clinical and treatment background questions before we conduct a discrete choice experiment, because it puts people in the mindset of thinking about their disease experience and their treatment experience, so they can, you know, they kind of they're in that mindset when they're completing the preference questions. So in this case, we included quite a number of background questions. As you can see, we included 14 background questions about their treatment history and disease history. Then in section 2, what we did is we asked questions on a Likert scale about how concerned patients were about particular aspects of living with lung cancer. This was a secondary research question for this project. So you may or may not include something like this in the survey that you're developing. But it's just here to illustrate that you don't have to limit yourself to just the preference survey or the preference experiment in your preference survey. We also like to include free response options, which allow patients to let us know if there's anything about their experiences or their preferences that we have excluded. And in this survey, we did that throughout the survey at different points. This can often allow patients that feel that we're leaving something out that's very important to them. Those patients may sometimes not fully engage with the survey because they feel their voice isn't being heard or being represented. But if we allow them to give a free response option, that sometimes then makes them feel as if you know, that they have been able to describe what is in fact most important to them, and then they can focus on what we're giving them in the choice experiments. A little bit of a word of warning: if you're doing, particularly if you're doing a study for industry, or if industry is a client, that including free response options always carries with it the risk of the reporting of adverse events, which then of course you know, need to be further investigated and reported. So it can be a little bit risky to do it. So you may not, for your survey purposes, may not want to include free response options. Then what we did in this survey is we had an entire section asking patients about the side effects that they had experienced and how important those side effects were in thinking about their treatment. We included this for multiple reasons. One is we wanted to know how many patients had experienced certain side effects. Another reason was that as you may remember from the choice test that we show, we didn't specify what short-term side effects patients, the type of short-term, long-term, or late onset side effect in the choice task. Because we didn't specify it, we wanted to make sure that we asked patients questions and we kind of probed them into thinking about what short-term side effects really were and what their previous experience had been with them. So in this section, we were, in a sense, able to, describe what types of side effects are short-term side effects, and we were able to get patients to start thinking about these side effects and whether they experienced them and how that impacted their treatment experience. So we did this for both the short-term, the long-term, and then the late onset side effects. Keep scrolling. And then after all that is when we get to the discrete choice experiment. So we have, let me see what page we're on right now, but yes, so 10 pages of survey that isn't discrete choice experiment for a patient preference survey. When you start your preference section, you want to explain to patients briefly what it is that you're wanting to learn and what you want them to do. So, you say, we're interested in your preferences and we want you to, we're going to show you different treatment options and we want you to make choices. You also want to introduce the decision scenario. So in this case, we were trying to get patients in a mindset of, hey, you consider that you are newly diagnosed. Which treatment option would you prefer? We asked them to think back to being newly diagnosed if they were in a later stage of their disease, to try to get everybody sort of on an equal decision perspective. Then what you do is you have to introduce the attributes you will be including in the choice task. This is the way that you describe these attributes is really important. You need to make sure that participants understand the attribute and the levels, and that they're interpreting it in the way that you think they are interpreting it. So pre-testing this, asking real life patients what they think of your descriptions, and then iterating on the descriptions is extremely important to make sure that you're developing a valid patient preference survey. What we also like to do is include a question after the description of an attribute. And we frequently call this type of question a throwaway question. It's not a question that you are necessarily very interested in analyzing, but it makes sure that participants read the text on the page and are thinking about the attributes and engage with it in a way that they, instead of just clicking through the survey. So we're explaining the attributes. We include a throwaway question for every attribute. Then here we have risk of late onset side effects. Risks can be fairly tricky to communicate to patients. It's a highly numeric attribute. Probabilities, especially very small probabilities, can be pretty difficult to interpret. So you have to take some care in explaining your risk attributes. In this case, we used these risk grids where we have 100 little pictographs, and the blue pictographs are the the number of patients out of 100 that experience a side effect. So you may want to include a visual when you have a risk attribute in your choice task, but you want to make sure that that visual actually adds to the understanding of the attributes and the levels. You also need to pre-test these visuals. In the survey, funnily enough, at the beginning, one of the first versions we had, these little, the blue pictographs were colored black, and we received some feedback that was too stark and too harsh, so we had to change it to blue for participants to be more willing to engage with the survey. And then we included mode of administration, we explained that, and then we asked patients once again, are there any things that that are important to you in your treatment decision making that we didn't include here? Then you include generally an example task. In this case, we described a person, Mary, who was completing the survey. She saw this choice task and she chose drug B. Of course, you can also actually ask participants to do their own choice task, to do an example task themselves. Sometimes we like doing it this way, where we show hypothetical participant that has completed a question, because we can re-emphasize that this participant had to consider all of the characteristics that were listed as part of the choice task in their decision making. So we can re-emphasize that the idea is that you consider all the attributes and not just one of the attributes in your decision making. And then it's finally the participant's turn to complete the choice tasks. So once again, you explain what they're going to be doing. You reintroduce the decision scenario. So this idea that, consider that you're newly diagnosed in this case. And then it can also be helpful to explain that these treatment profiles are hypothetical, and that some of them may not sound realistic. Some of them may sound really bad. Maybe sometimes both of them are really good and it's hard to make a decision. But that we're not really asking about, but that we still want them, even if it's hard choices or choices that they think are unrealistic, that we would still really want them to answer this to the best of their ability. So then participants completed 10 choice tasks. It can be very helpful in the middle. I don't think we did it in this survey, but it can be very helpful to kind of include some word of encouragement halfway through. And then something we've done, are increasingly doing in our surveys, is that once they've completed the choice tasks, we ask them to evaluate what they thought about it. So we asked them, were you able to understand what you were supposed to be doing? Were you able to answer the choice tasks? Do you think you answered consistently with your preferences? And then do you think these questions were relevant? And this can really give you some insight into how difficult the survey was and whether participants feel that they were participating in something that matters to them, and that they feel like their answers are reflective of their real preferences. And then after the choice section of the survey, we generally include some questions about just basic clinical and sociodemographic features. And we do this after the choice tasks because these questions can sometimes be sensitive. So for example, race or ethnicity, or maybe income. And we don't want patients to see a sensitive question like that, not want to answer it, and then drop out of the survey. We prefer them to answer the choice task and get insight into their preferences before they drop out. So I know that was a whirlwind. What I would like you to take away from this is that a preference survey is not just the choice tasks that you're going to be presenting. It's an entire complete survey. You have to put thought into how to develop it. I am now very quickly going to go through the data analysis. These slides will be available to you. So even if I rush through them, I hope that you can read through them at a later date and get a better understanding. But we've developed the survey, you've conducted the survey, you have your data. Now what do you do? So the first step is that you need to import and clean your data. And one of the things that's interesting about many forms of stated preference methods, and in this case, the discrete choice experiment, which we're going to be looking at, is that you will download your data or you will receive your data in wide format, where, for every respondent, you get one row, and then you get the choice that they made for each choice task. So in this case, participant 1 for choice task 1 chose person A, and for choice task 2, they chose person B. And then participant 2, they also chose A for task 1 and B for task 2, and then person 3 and person 4. So every participant has a row. And generally what you need to do in a preference setting is you need to transform this wide data set into a long data set, where every choice task, every option, so every profile that a participant has seen becomes a row in the data. So if you have 10 choice tasks in your standard 2-profile DCE, that means that you have 10 times 2 rows per participant, so 20 rows per participant. I'm not going to dwell too much on the data setup because we have limited time, but this just reiterates that it's a wide or a long decision, a long data format now. And what happens is choice becomes a dependent variable where, in this case, for participant 1, task 1, the profile 1 or alternative 1, they chose, that was the option that they chose. And then, of course, because it's a either or, for choice task 2 of task 1, participant 1 did not choose that option. So choice becomes a dummy variable. This respondent task column is also an important variable, which groups the profiles by task. So it tells your software that task 1, alternative 1, and task 1, alternative 2 were shown to the participant together, and they were choosing between those two alternatives. So it groups alternative 1 and alternative 2 for each choice task. So for choice task 1, you have 101 and 101, and for choice task 2, you have 102 and 102. So it's a unique indicator for each participant and each choice task. When we think about data analysis, there's the three, I think I can say this, the 3 most commonly used models are the conditional or multinomial logit model, the mixed or random parameters logit model, and a latent class analysis model. Conditional logit model is the most basic model that assumes that choices are fixed across everybody. So everybody has the same preference. Your mixed logit model assumes a distribution around a preference. So my preference may be different from Brett's preference, maybe different from John's preference, and maybe different from Nora's preference, but we're all nicely kind of, it's a continuous distribution. We all fall somewhere along the distribution. And then the latent class model assumes that there are distinct classes of people that have different preferences. That can be grouped based on, you know, distinct sets of preferences. When you set up the conditional logit model, or any preference model for that matter, choice becomes your dependent variable. And this is a dummy variable. And then the attribute levels are your sets of independent variables. And there's different ways of coding your attribute levels. You can code them as continuous variables, or you can code them as categorical variables. Depends on the attributes you include, it depends on the levels you include, and it frankly depends on how the preferences shape out to be. So you may include a numeric attribute, but when you look at the preference estimates, you see that there's a clear nonlinearity in how patients express their preferences. So you have your dependent variable choice, you have your independent variable attribute levels. You tell the model which choice tasks appear together. So you include this grouping variable. And then in this case, we also adjusted the standard errors. The results that you get are preference estimates, which in a sense tell you how much a attribute level was preferred over another attribute level. So in this case, to help you interpret this, this table is just put in graphical format here. A more positive preference estimate or model coefficient indicates that the attribute level was preferred over a different attribute level. So in this case, 18 months was more positive. It was preferred over 12 months of progression-free survival, which was preferred over 6 months of progression-free survival. That's to be expected. The actual absolute number here means very little, as Brett had already kind of alluded to earlier. It's the difference between the preference estimate for the attributes that's important. When we look at functional long-term side effects, as expected, we see that no side effects was preferred over mild side effects, was preferred over moderate side effects. So that also moves in the direction that we had anticipated. You can also analyze your data based on a where you include your attribute levels as continuous variables, and then you receive preference estimates that indicate the change in utility that you get when there's a one unit change in that attribute level. So in this case, if there's a 1 month increase in progression-free survival, utility goes up by 0.1 something. And I kind of wave my hands and say utility because it's a little tricky to interpret these sometimes, because there's no there's no unit associated with preferences. We're not dealing in meters or milliliters or moles or a unit. You can calculate marginal rates of substitution. I won't go into this, but the way to think about this is that you can calculate what trade-offs patients are willing to make between different attributes. Then there's the mixed logit model that I discussed before. When you're setting up your model, it's very similar to the conditional logit model, where choice is still your dependent variable, and then you include attributes and attribute levels. In the mixed logit model, one of the things you have to do is specify which of your attributes you think have a preference distribution associated with it. So for which attributes is there preference heterogeneity present? Then the results that you get for the mixed logit are you get a set of preference estimates, similar to the conditional logit, but you also get a sense of the standard deviation or the distribution around those preference estimates. So again, graphically, what this means is that, on average, the average person loses 0.5-ish utils when there's a one-step increase in the severity of functional long-term side effects. However, these preferences are distributed along a distribution. So 95% of participants, so while the average participant will see a decrease of 0.5 utils, 95% of the participants or patients will have a preference estimate that lies somewhere within this distribution. There's a difference in how patients view the change in long-term side effects. You can, of course, stratify these results based on observed characteristics. So, for example, you can see how men and women have different preferences, or you can think about how preferences may differ based on treatment experience. And then the last model I want to very briefly discuss is the latent class analysis, which is rather than stratifying preferences based on a pre-observed characteristic. So rather than saying, well, I wonder how what the preferences are of men and what the preferences are of women, you take your data and you see whether there are there are groups of people that have just shown different preferences. So you group people based on the preferences that they have expressed rather than based on a pre-observed clinical demographic characteristic. The latent class model, when you tell it how many classes you want it to run, it will give you preference estimate for each class. And it will also tell you what the proportion of participants is that are expected to be in each class. So in this case, we had a 2-class model. 37% of the participants fell in class 1 and 63% fell in class 2. Selecting the number of classes for latent class analysis is quite tricky, and it's kind of a combination of an art and a science. And I think we could spend an entire hour discussing it, so I won't get into it. Well, Nora, that was it. I know that was a whirlwind, but I would be very happy to take any of your questions now or later.
Thanks, Ellen. I think we were actually able to get to most of the questions in chat. So thank you for being so efficient. And if there were any final questions, if folks want to pop them up now. great. So as we go into our last 30 minutes of this session, I'm going to close this out by talking about kind of the fun part, which is how we wrap all of this together. And I'll do that through a few illustrative case studies. So we'll start with the threshold technique. So the study that I'll be talking a little bit about today came from Brett Hauber, I believe was the analytic lead on it, but it was also conducted in partnership with the Michael J. Fox Foundation, MIT, and the Medical Device Innovation Consortium. And it was really looking to better understand and how to develop a patient-centered clinical trial for a Parkinson's disease device. So the first stage of that was identifying some outcomes and potential benefit and risk trade-offs that might be meaningful to people with Parkinson's and those who loved them. And also the second step then is about how do we actually document these patient preferences and these caregiver preferences, and how do we measure those things for use later on throughout the clinical trial. So in partnership with the FDA, Michael J. Fox Foundation, RTI, the 5 different benefits were identified for Parkinson's. So as many of you probably know, Parkinson's is a progressive motor disorder. It can be characterized by a diverse motor symptoms. It has a very heterogeneous presentation. One of the main I guess, impairments for someone with Parkinson's is kind of something called like on time and off time. So on time being a time wherein medications are working very well for people with Parkinson's, they're able to manage their symptoms, kind of have a higher quality of life, as comparison to off time, which is when when the medications are not working well, patient might be experiencing tremors or other sort of symptoms that are impairing their ability to kind of live life to the fullest. So one potential benefit of any device that would improve the life of someone with Parkinson's might be something that increased this daily on time when they were really alert and aware and feeling good. Other benefits might include something that had a decrease in the motor symptoms, negative motor symptoms, a decrease in Parkinson's related pain, a decrease in cognitive impairment, and a decrease in medication and side effect burden. So as these benefits were sort of shaped through discussions with people with Parkinson's, caregivers, FDA's regulatory and scientific knowledge on the topic. And then in the survey itself, which perhaps looked something like what Ellen just presented, there are actually these self-reported questions wherein folks report for themselves individually how much time of their day they would have spent, and that was on time versus off time, what their severity of their motor symptoms was, how much pain they were in, and so on and so forth, so that the researchers had a sense of how important each of these different items were to people living with Parkinson's. In contrast, we also need to think about benefits and risk trade-offs, right? It's not just that if everything was always going to be good, there wouldn't be anything to trade off for, and we wouldn't perhaps need to think so much about preferences. But it's because of these trade-offs that preferences really matter. So while there is a potential for all of these devices that might improve the health outcomes that matter most to people with Parkinson's, there's also these potential risks that might come along with them. One of them being a potential risk of worsening anxiety or depression, a serious risk of a brain bleed. This was a device that was proposed to be implanted in the person's brain, as well as an increase in mortality. So in the threshold technique, respondents were presented with a lead-in wherein the survey would read, earlier you told us that you experienced X hours of on time, and that X hours would have been a number generated by the person themselves reporting on how much on time they experienced. So you told us how many hours of on time you experienced each day when your current Parkinson's treatment was working, and to improve your symptoms with Y hours of off time each day when your current Parkinson's treatment was not working. Suppose you could get a device implanted in your brain today that would increase the number of hours of on time you had from X to a larger number than X each day. And that was about 50% increase is what we were looking for. So that would be our potential benefit, is that we have this device implanted, but it increases the number of hours in which patients with Parkinson's are really feeling good. Now suppose that 20 out of 100 people who got the device will develop depression or anxiety. So that would be the potential trade-off. As you get this device, it increases on time, but in contrast, it also increases your risk that you might have depression or anxiety. And then please assume that there are no other benefits or risks or side effects that are coming from this device. So below, so this would be the technical lead-in, that kind of first page that Ellen showed you. This is what's going to happen. And then the respondents would actually be completing the choice question. So as you can see here, I talked at the beginning that there were 5 different treatment benefits. For each of these, they were displayed for all of the participants. And you can see that in these non-shaded boxes, they're actually the same. So this current treatment that people would be on in this new hypothetical device were similar across many of these domains. So actually, they were similar for that was a misleading first example, but they were in this scenario, they were similar for the number of hours of on time and the severity of pain that patients would experience, the difficulty thinking clearly, as well as risks of bleed and risks of dying. But we also vary them systematically across both a benefit and a risk. So the benefit that was being systematically varied was this motor symptoms. So you can see that this new device would have fewer motor symptoms or an improvement in motor functioning. But it would also come with the added risk of anxiety or depression. And I'm very sorry about my dog, but once I so in the threshold technique, I'm sorry, everyone. In the threshold technique, respondents would first be presented this first question that they would receive is this target depression question. So if the targeted risk is 20%, a 20% risk of depression or anxiety, would you take this new device? And they have a choice to either take that or not take that. Then what happens is based on that choice, the next question actually varies. So if a respondent indicated that they would assume this added 20% risk of depression in exchange for a treatment that reduced their motor function or improved their motor functioning, what happens is that the threshold technique, the next question would actually jump to one wherein the targeted risk was doubled. So we'd say, okay, if you're willing to accept a 20% risk of depression, would you also accept a 40% risk of depression? And on the opposite side, if folks said that they would not choose this 20% risk, we then drop it down. We say, okay, we see the 20% was too much. Is 10% appropriate? And then you vary that a third time. And so by that end, you actually end up with a pretty nice understanding of how people's risk tolerance varies, not just whether they would or would not accept 20%, but really what risk they would accept. Is it kind of below 15 or is it kind of above 40? So from that survey work, what you're then able to do is to calculate a maximum acceptable risk for how much risk someone would take for an increase in any one of those potential benefits. So in this case, we'll take this daily risk of on time. So on the x-axis of this chart, you have the increase in hours per day of on time when patients are feeling good. And on the y-axis, we have the maximum acceptable risk, or what percentage of risk people would take on. So if you look at depression, that's that red bar, it's kind of the steepest slope. We see that for a treatment that would improve on time by 8 hours a day, respondents would on average accept a 20% risk, just around a 20% risk of added anxiety or depression. So that gives us a good sense of if the treatment came out and the clinical trials came out to say that 1 out of 5 folks would develop anxiety or depression, but they would also gain 8 hours a day of on time, that treatment would probably be acceptable to a good number of people. That's not the case for all of the risks, however. So if we look at something like brain bleed, that's our orange bar, we see that what percentage of risk someone would be willing to accept on average is much lower than something such as anxiety or depression. So for an increase in 8 hours a day of on time, someone might only be willing to accept on average a 5% increase in risk of a brain bleed, or even lower than that for death, around a 3% increase in the risk of death. So this benefit risk trade-off varies depending on the risk that's being assessed, which of course makes sense. We can also think about this in terms of course, that was just an example for on time, but there were 5 different benefits in the survey. So overall, any single respondent would have received kind of a smaller subset of the survey that varied across a particular benefit or a particular risk. But when you have these very large survey panels, what you can do is send out slightly different versions of the survey to very different, or to the kind of your same sampling frame, but some slightly different versions of the survey, so that you're able to get this bigger understanding of the context in which these benefit risk choices are being made, and be able to derive kind of more information from more folks without overburdening any single individual. So what you see if instead of varying that amount of on time, if you start to vary cognition, and look for people's trade-offs, what you see is that there's a pretty big, folks were willing to accept kind of a pretty strong, a relatively high risk of depression in exchange for reducing cognitive impairment, so having improved cognition. We also see that, and these are the sort of median levels offered by the attribute itself, that there's a relative similarity in terms of the kind of maximum acceptable risk of depression that folks would report accepting in exchange for a treatment that improved on time, or a treatment that improved movement, or a treatment that had some pain benefits. Finally, we see one of the other attributes was the kind of mode of administration. And what you see is that the, switching, having fewer pills per day is simply, and as compared to the rest of the benefits, just not really as meaningful in terms of how many, in terms of your risk tolerance for it. So folks are just less willing to accept a risk of depression, brain bleed, and death if the only kind of benefit that they're receiving is the number of pills per day they're taking is reduced. So it perhaps is not as much of a mode of administration problem. So that was our threshold example in the wild. And now we'll move into our best worst scaling, case 1. So as Brett described, there were 3 different types of best worst scaling. Case 1, which is perhaps the most common, is looking to rigorously prioritize objects or perhaps endpoints or outcomes or kind of objects without levels. So for instance, in this case, we're going to talk about the prioritization of potential treatment benefits for people with the condition Prader-Willi syndrome. Prader-Willi is a rare condition. Its sort of hallmark characteristic is hyperphagia, which is an insatiable hunger. It really, insatiable almost kind of undersells it. It's really kind of like a life debilitating obsession with food, which actually results in the death of some people with Prader-Willi syndrome. So it can be very severe. But there's a whole host of other intellectual and physical burdens that kind of come with Prader-Willi. And so the Prader-Willi community identified some possible outcomes that were meaningful to them and for which they wanted to better understand what mattered most. And the idea here is that if you can understand of all of the different things that are going on in Prader-Willi, what's kind of most meaningful to explore, it helps give a sense of where should future research be focused and what's the importance of prioritizing one outcome or measuring one outcome in comparison to another. So the Prader-Willi group, along with researchers, Dr. Bridges was on this work, looked at, I believe, identified 7 potential outcomes that they wanted to prioritize, including improving intellectual functioning, decreasing gastrointestinal problems, improving hyperphagia, that's that characteristic, insatiable hunger, decreasing overweight, decreasing anxiety, decreasing temper, and decreasing skin picking. So here is once again an example task of the best worst scaling. So respondents, in this case, respondents were actually caregivers of people with Prader-Willi syndrome. People with Prader-Willi syndrome are often have very limited intellectual functioning. So for this particular patient population, the survey was kind of exclusively caregivers, though it's less common that that's the case across most disease areas. You generally, even conditions that kind of have a pediatric onset, would think about including both the patients as well as the caregivers in that surveying. So anyway, the caregivers were asked, what do you think is the most and least important consideration when choosing a treatment for your family member with Prader-Willi syndrome. And of course, would have selected their most important and their least important. In total, around 500 folks, just short of 500 people participated in the survey. There was, of our 7 outcomes, what happened was that the hyperphagia outcome really kind of stood out as being selected best the most number of times. So 872 times respondents said that hyperphagia was the most important to them, or the kind of best outcome. On the flip side of that, only 140 times did people say that reducing gastrointestinal problems was the most important outcome. So you start to get a sense of, okay, people are saying hyperphagia is the most important, a lot more than some of the other items. And they're also saying it's the least important far fewer times. So people are really heavily favoring hyperphagia. What we can then do is generate this best worst count, which is simply the number of times something is chosen as best minus the number of times something is chosen as worst. And then adjust for the number of times in which that item was offered over the entire choice experiment to all of the different respondents. And then, of course, you simply convert that to onto a 10-point scale, wherein 0 would be kind of no preference at all, and 10 being the absolute most important outcome. So once you standardize all of those, you get a better sense of how these outcomes stack up against one another. So not surprisingly, based even on just that simple best worst count data, we see that hyperphagia was the most important to this group of respondents, and it kind of is the most prioritized outcome, perhaps the thing that folks would want to be improved upon most as drug developers and researchers are looking to improve treatments in this condition. And then further, as we go down the line, it's not as though other items aren't important. We still see that folks are saying that each and every one kind of has some importance in their life. And that would make sense because these were outcomes that were generated in partnership with a community group itself. But just simply that relative to hyperphagia, some things are less important. So focusing on skin picking or gastrointestinal issues, still very meaningful, but not at the top of the priority list. And then a fun feature of this study was this sensitivity analysis looking at differences in prioritization of outcomes across ages of people with hyperphagia, or I'm sorry, people with Prader-Willi. So as we begin with, the survey was eligible for around, I believe 4 years and older. Caregivers of patients 4 years and older were eligible to participate. And what you see is that at that very early stage of life, hyperphagia is kind of far and away the most important in terms of its prioritization relative to the other outcomes. And it stays certainly close to the top, but by the time the age of the person with Prader-Willi was older, kind of in this 50s, we start to see that that other objects become important as well. So anxiety, or intellect rather, kind of seemed to take a dip in the middle years here. It didn't seem to matter quite as much. Actually, for a very brief period of time, was perhaps the least important. But among folks who are older with PWS, it really starts to peak in importance as folks become older. So while the items, I wouldn't say that they kind of dramatically shifted in terms of their importance overall, things still kind of overall were important to folks, there was this changing in the relative importance of these outcomes over time. And finally, our direct elicitation and discrete choice experiments. So the study that I'll talk about today looked at patient preferences for non-small cell lung carcinoma, specifically this EGFR mutation malignancy. And it used 2 different preference kind of expression methods, one being our direct elicitation. Direct elicitation is kind of quite simply saying, would you use this, would you want this, or directly comparing 2 things, saying, do you want this, do you not want this. Discrete choice experiments, of course, are different in that they use these systematic experimentally controlled designs to try to better understand the trade-offs that folks make for different attribute levels, particularly with regards to kind of severity in this instance. Yes, so as I mentioned, direct elicitation, these profiles represent kind of realistic choices and can help us get an understanding of what proportion of participants would choose one specific treatment over another. So for instance, you might present all of the facts to a person with cancer and say, would you like chemotherapy? And these are all of the things that will happen if you get chemotherapy, or would you like surgery? And these are all the things that would happen if you get surgery. And that information allows us to estimate a proportion of respondents who would choose these very realistic trade-offs, which of course vary in their attributes, but we're not necessarily looking for how the attributes themselves differ. We're looking at how the choice overall differs. And then discrete choice experiments, as you all now know very well, don't necessarily represent these realistic choices, but really are about trying to understand how benefit risk trade-offs might vary across these unique levels of attributes. So we're not looking to say, are you going to take chemo or are you going to take surgery? We're trying to say, okay, so what is it kind of about these different objects that might force you to choose one over another? What are these kind of linchpins that you care about? So this study was recruited from a national survey of US participants as part of an online sample, I believe. And they used 6 attributes, each with 3 levels each. And those attributes and levels were generated from this sort of standard, but good practice, literature review, and qualitative interviews with experts and patients. So the attributes included progression-free survival of 6, 12, and 18 months, side effects of rash, diarrhea, nausea and vomiting, and fatigue, and potentially mode of administration that would vary potentially across the treatments. This is an example of the direct elicitation question that would be asked. So what would first happen is that respondents would be shown this direct comparison 1 and asked to make a choice between treatment A and treatment B, where treatment A had a shorter term progression-free survival, but very few side effects, right? So you're only going to have 6 months without of a progression-free survival, but relatively low risk of rash, relatively low risk of diarrhea, and kind of no risk of nausea or fatigue. In comparison to treatment 2, which has a much longer progression-free survival, 18 months, but comes with this much larger risk profile for all of these different considerations. So respondents would first make that choice between treatment A and treatment B, and then would be asked to make a choice between treatment B and treatment C. So in this scenario, treatment B is again the same as our first treatment B, as again, it's this long progression-free survival with many side effects. And then we have kind of the intermediate example, which is sort of a mid-range progression-free survival, but still with a few side effects, but relatively mild side effects, certainly as compared to treatment B. And this data is analyzed not necessarily using a regression analysis, but can really be analyzed just using simple frequency and kind of descriptive statistics. So in direct comparison 1, around half and half of folks were split between this kind of 6 months of progression-free survival and 18 months of progression-free survival, knowing that it came with this really high risk profile for side effects. And that perhaps makes sense. We can think about, of course, this question would beg for me, is there some sort of underlying phenomenon? Perhaps some people really care about side effects. Perhaps some really care about just kind of longer life expectancy or progression-free survival. But then when we look at comparison 2, we see a slightly more dominance for treatment C, which is this 10 months of progression-free survival at this low level of risk relative to this long period of progression-free survival at a much higher level of risk. And that really tells us that while some participants might opt for the shorter progression-free survival in exchange for more favorable side effects, but are perhaps less likely to do so. So that would be our kind of scenario A, but are perhaps less likely to do so if these differences are kind of very, very large. So then the same study used these very similar attributes to explore differences using a discrete choice experiment and to better understand how the particular preferences for these attributes and their attribute levels might vary, and also so as to calculate time equivalents and specific trade-offs for the importance of side effects. So finally, what we have here, these would be results from the discrete choice experiment analyzed using the conditional logistic regression model that Ellen described. And how to read this chart is we have the attributes and levels on the x-axis, and then on the y-axis is the required change in months for progression-free survival. So for instance, in progression-free survival. So for instance, someone would accept a change of rash from mild going to a moderate chance of rash if it improved their progression-free survival by 3 months. So that's sort of equivalent. Was 3 months of progression-free survival is equivalent to going from a mild to a moderate rash. I think the most extreme example here is that respondents indicated that they would be willing to take on up to 15 months of they would be willing to take on severe nausea and vomiting as compared to mild nausea and vomiting if it extended progression-free survival by 15.5 months. So we can just see how while the direct elicitation data helped to clarify specifically what treatments folks might be more interested in taking, the discrete choice experiment can provide more information regarding specific trade-offs that people are making and the equivalency of different, when you want to compare specific attributes to one another, such as by how much can we increase nausea or vomiting if we also know that it's going to extend someone's life? Where's the tipping point there? So I think that is it for my component of this. So it's 3:47 now. I'm happy to take a few questions on those case studies, but also we have this time, I think, opened up to all of our panelists to speak about their experiences and questions, answer any questions you might have.
Nora, I saw a question pop up from Ram in the chat box about experimental designs that may be directed towards John. So Ram asked, he said, I noticed generally many attributes and levels used in DCE surveys. Could you comment if the fractional, factorial, or inclusion of main effects only have been the standard / acceptable for publication? Perhaps other design practices exist to address this issue.
Thanks very much for the question. Most studies, I've only found 2 ever that didn't use a fractional factorial. Doing a full factorial design is fairly rare. And there was one study where I saw radiologists in the Netherlands look at 130 profiles and make a decision on each. So some groups might be able to do very large numbers and therefore avoid a design issue like that. But generally, most published studies, whether they say it or not, are using a fractional factorial. So that's not the issue. The question now becomes, what was the design principle? There are some people out there that say, well, actually, one of the designs just could be random. If you just randomly pull out profiles and pulled out enough of them randomly, then it might be acceptable. And that's certainly been used in business and in consumer products and others. Less used. I don't remember seeing a random design in health. So that means we're in this kind of world of optimality. And there are several different focuses on optimality. There was what traditionally used to be called Street and Burgess optimalities. Most of the optimalities will focus on having 0 priors, which means you estimate, you're believing that all the betas are going to be 0. And under that condition, you can easily get orthogonality, level balance, and minimum level overlap. Again, however, most of these designs, whether it's a D-optimal, whether it's an N-gene, whether it's a many designs, generally that's the area that computer-generated designs are going to go in. But the problem is the more orthogonal a design becomes, whether it's main effects, which is 99% of the designs out there, or having a specified interaction, most of them are going to have this issue associated with the more orthogonal you get, the more likely people aren't going to tell the truth. And so this is the state of the art. Now, a couple of ways around it. You could tell the experimental design what the betas are going to be. This is a Bayesian design, and then you could continually update that. We've had some difficulty with Bayesian designs because some of the attributes get highly correlated, or more importantly, highly negatively correlated. So imagine the studies that have potentially two primary benefits. I've worked in blood cancers where you might consider both survival and chance of remission. One of the problems is that it'll either offer you a higher chance of remission or it'll offer you a higher chance of survival, but it can't offer you both because that's just way too much benefit to show you, and it'll always outweigh the risks. Because of these, we can sometimes see some unusual results. A lack of monotonicity in some of the key attributes, where mild, moderate, and severe, and people like moderate more than mild, and we scratch our head and go, I don't understand why this is happening. It's got to do with the correlations that enter in. The net of it all is experimental design really scares me. When I get down and have proper conversations with pretty much everyone around the world, they tend to conclude, including some of the top academics in this area, not in health, that we probably still don't understand the ideal characteristics of experimental design. So because of this, some people have been talking about stripping it back and doing natural designs, which is trying to give people profiles that may exist in the real world. Brett talked about hypotheticals, and sometimes some of our hypotheticals are not quite, we do the good, bad, and ugly because we have to estimate trade-offs. But because of this, we can sometimes put some pretty implausible things out there to maintain the properties of this experimental design, and that causes problems. So that's moved back to a couple of other methods, non-experimental methods that could be these trade-off techniques or generalized standard gamble or threshold techniques that could be estimated in other ways without randomizing profiles. Or potentially, like we saw in the last case study, can we answer the question just by putting a handful of profiles up and understanding not how people make trade-offs across those attributes, but potentially across the three profiles, and then try and dig deeper with open and closed probing as to why the differences exist, rather than trying to specify it in a model. But I think this is a very challenging scientific question.
So I'm just going to follow up with my question, if that's okay. I'm often given a whole bunch of patient responses and then have to somehow come up with something from that, as opposed to having the forethought and time to go through and have a nice design that you've shown in your DCEs. I'm wondering if there's tools when it comes to true false preferences or others where they fill out a questionnaire and things that you can look at that from those responses as opposed to starting from scratch. Does that make sense?
I think these types of preset scenario or preset surveys, it has many of the same problems that we deal with in revealed preference. You know, there's only a certain number of particular phones available at any particular market and any given time, and you know, the available phones in a poor neighborhood may be different in a rich neighborhood. So we potentially could have these questions that ask, why were the questions asked in their way? So there could be confounders, omitted variables, other reasons that presented the combinations in a way that we did. I don't want to throw that data out. I think previously, if you met me when I was 10 years younger, I would have said, oh, that's all completely wasteful data. You've got to control it from the beginning. Having done many studies, 100 publications on this, I probably could say maybe there's something in that data, and maybe we need to explore it. But it's the same type of, do you want to compose value or decompose value? And to the extent that the variations or the profiles or the information that you can get may not be able to be decomposed in the way that a regression does because the attributes are not identifiable, then I think you have to start considering about compositional approaches. But compositional approaches is where you try and incorporate the Likert data or any ranking data and try and incorporate that together, maybe sometimes using arbitrary scoring. There's a lot in the, there is this reasonably solid literature on Asian meat preferences. Food safety has a big literature using these types of things, but there is a literature about Asians and pork and other types of work in that area that use these self-explicated types of hybrid approaches because they're actually trying to get motivated by a real question rather than having the opportunity to go and do a perfect experiment. But we find in other literatures examples of these questions that are maybe less controlled, less experimental, but do have some value. It's just a matter of sitting down, and I've applied some of the good research practices. So for example, in some of my work where I've just used Likert data, I've applied the standards that you would apply to a discrete choice experiment to try and interpret the biases or approaches. And when I do that, I find a lot more similarities between non-experimental and experimental data. If you're just bang through the numbers, sometimes you can get very stark differences. But if you can control and understand the circumstances by which questions were asked, remarkably, as a colleague of mine says, this data is generally very robust. You know, if preferences exist out there, generally any of the methods will pick up on them, and generally there will be some concordance between the different approaches, you know. So it's got to do with, is there a strong will in the people to have particular trade-offs or particular profiles or particular attributes? If it's strong enough, the signal to noise ratio will generally be sufficient that you can find a signal.
Thanks.
Thank you, everybody. I wanted to thank Nora, Brett, and Ellen and I have done this. Brett and I have done this, I forget how many times now. Ellen has participated a couple of times, but this is Nora's first attempt at helping being engaged in this. She played a really important role bringing the team together. We've never used 4 speakers before, so I really wanted to thank her for the effort that she's put in to make this short course happen, and the correspondence and quality control that went into the behind the scenes, the slides, putting them all on one deck. So thank you very much, Nora, for your efforts there. I think you did a really great job, and look forward to connect with the team moving into the future. But also what has happened, particularly in the past, is people continue with some conversations, and I know Brett and I in particular have followed up with people and even ended up being mentors on trainees' work, or contributed to their quality control or other aspects of their studies. So We are staunch believers of the ethos of the Society of Medical Decision Making. We've been here for quite some time now, and however we can help you understand the methods to measure the perspectives and values of patients and other stakeholders in decision making. We would love to connect with you and give you the resources to make sure that we can do this in a patient-friendly way, but also in a way that fully embraces the science of patient engagement. So why don't we end it there? And thanks everybody. I did send out an email, and if you want to ask some questions from the team, do follow up with us, and we're happy to engage. Thank you.